Good morning. Greetings from the cornfields north of Baltimore. I'm sorry we aren't able to meet in person, but I'd like to thank the organizers for letting me have the opportunity to provide my perspective on lung disease among persons aging with HIV. So in the next few minutes, I'd like to share some information about the potential mechanisms, epidemiological and clinical data on chronic lung disease among persons aging with HIV. I'll also briefly highlight some strategies to reduce this burden of complications and highlight some research gaps. I'm starting out here with what I'm not going to be focusing on. It's recognized that HIV has been associated with independent risk for lung cancer, pulmonary arterial hypertension, and other lung abnormalities. Ken is going to talk about sleep, but we just don't have time to focus on all of these other outcomes. So I'm going to be focusing on chronic obstructive pulmonary disease. NHLBI supported the pulmonary complications of HIV study back before the ART era was in full and widespread availability. This study really was the first longitudinal data to describe the increased respiratory symptoms associated with HIV and reported what is continued to be noted, the reduced diffusing capacity abnormalities, which were largely related to respiratory infections. Phil Diaz and colleagues at Ohio State identified radiographic abnormalities in a substantive proportion of HIV-infected patients. And this was followed by work from Christina Crothers in the VA system, both looking at diagnostic codes and self-reports over a variety of different studies, and looking at both the COPD prevalence as well as incidence, and identifying that HIV was associated with increased risk. These data have largely been confirmed in most studies, as well as in a large meta-analysis recently published, that HIV is associated with independent obstructive lung disease prevalence. In the combined study of the MAX and VAX, Christina, along with Allison Morris at Pittsburgh, demonstrated and followed up on the DLCO impairment, showing that it was notably higher to have reduced diffusing capacity associated with HIV, as well as that these abnormalities increased with the worsening severity of immune suppression. And in recent data presented looking at the hospitalizations of persons with HIV at a New York City health system, you can see that the increases year over year have been notably higher among those with persons with HIV for chronic pulmonary diseases compared to the non-HIV infected patients. And so with that brief overview of data from some esteemed colleagues, I'm going to focus on the SHIELD study, which is the study of HIV infection in the etiology of lung disease. We've been doing this work since 2008. Our study draws from two existing HIV cohorts, the ALIVE study, as well as the Hopkins HIV clinical cohort. It's predominantly lower income African Americans with a history of injecting drugs, and we follow both HIV infected and uninfected participants. Over the years, we've recruited almost 2,600 individuals. They undergo 6-month evaluation with detailed respiratory questions, clinic-based spirometry, and we now accumulate a very large biorepository. Among a subset, about 500 have undergone full PFTs and high-res CT scans, and another subset have undergone bronchoscopy with collection of BAL fluid. So what are the mechanisms for HIV increasing COPD risk? Well, we know that the HIV population is aging, and we also know that after age 30, lung function typically declines with age very predictably, and that this decline is accelerated with smoking. And also that clearly COPD prevalence increases with age. So there is the hypothesis that aging, the increased burden of disease is really reflective of the increased survival of HIV-infected populations. However, there's behavioral factors at play, with the elephant in the room being smoking. We've recognized here in a variety of different study populations that smoking is much more prevalent among HIV populations than it is in the general population. This is our study population with around 85% active smokers among our SHIELD cohort. So we were concerned that confounding of increased smoking by HIV status might explain some of this observed effect. But among the first 1,000 of our patients, you can see that while, again, the prevalence of current and former smoking is almost ubiquitous, the differences in smoking behavior are not apparent, and that HIV positive patients, really, the smoking behavior shouldn't explain observed effects. Of course, we do adjust for smoking behavior in all of our analyses. In addition, we also have a variety of infectious etiologies that are presumed to contribute to COPD risk, be that bacterial pneumocystis or the underlying microbiome in the lung, as well as we're very interested in what are the direct effects of HIV infection, as well as potential contributions of the antiretrovirals themselves. So in longitudinal follow-up over about a 3-year period of 1,000 participants in SHIELD, we noted that there was the expected annual decline in lung function among the HIV negatives. Again, we're accounting for a variety of demographic factors. And we can see that at baseline, HIV-infected patients had about 150 mLs lower of absolute FEV1, and during follow-up, they had a slightly increased decline in lung function. But it's really among those individuals with higher viral load that had a clinically significant, almost 100 milliliters per year average decline in lung function. We also have replicated the DLCO findings, and here, accounting for both the level of quantitative emphysema as well as COPD status, we see that the HIV-infected patients with or without COPD have an increased impairment of their diffusing capacity. We've also looked at acute exacerbations of COPD among our HIV-infected and uninfected COPD patients in SHIELD, and there's about a 2.5-fold increased risk associated with HIV for acute exacerbations. And importantly, healthcare utilization and quality of life are important endpoints. In looking at the medical outcomes survey, physical and mental health scores, HIV was associated. The physical and mental health were reduced by impairments in lung function. If there was a substantive decrease in FEV1 over time, we see that there were significant impacts predominantly in the physical health quality of life scores. And notably, this effect was most prominent in those, again, who had the poorest viral control. Similarly, again, we see an HIV effect modification where if you had substantive declines in lung function over time, you were more likely to go to the emergency room or to be admitted to the hospital. And once again, we see that those with detectable viremia had the greatest impact associated with the lung function decline. And finally, obviously, we wanted to look at the impact on overall mortality. Among those individuals in SHIELD who did not have obstructive lung disease at baseline, we found that it was only among the HIV strata that had significant, that incident obstruction, a new diagnosis of COPD actually was associated with a notably increased hazard of mortality, whereas this effect was not observed among the HIV uninfected population. So some consistent data that HIV does impact a variety of clinical outcomes, and a recurring theme that poor viral control is associated with effect modification of these associations. So what can we do about this increasing and large burden of morbidity related to lung disease? Well, first, we need to be better at screening and diagnosis. In SHIELD, only about half of patients who met spirometric criteria were aware of the diagnosis. Not surprisingly, the more severe the disease or the increase in symptoms, the more likely you were to have been diagnosed. We tried to address this in our HIV clinic by implementing a guideline-based screening questionnaire based on age, if you were a smoker, had any respiratory symptoms. Among around 900 individuals, there was a pretty good yield from this approach, with 1 out of 4 screened individuals needing referral for spirometry, and of those who underwent testing, 1 out of 4 actually had COPD. However, as you can see here, there was substantive drop-off in both the patients and the providers completing the process to get the referral completed for spirometry. So we needed to be better at screening and diagnosis, and we need to make sure that it's not just the spirometry that we're doing. We recognize that diffusing capacity abnormalities, often in the absence of any obstruction, is a heavy player in terms of respiratory disease, and we need to get diffusing capacity. We also need to take a very implementation science approach to implementing tailored smoking cessation, as well as recognizing the syndemic of HIV, substance abuse, and comorbidities. And we can leverage the same factors that make it difficult for an HIV-infected patient to take their antiretrovirals, also likely contribute to their ability to maintain smoking cessation or self-manage their comorbidities. We can leverage this syndemic perspective to actually not be siloed and focus only on the one disease or HIV only, but to make a more holistic approach for reduction of risk factors in managing diseases. What about next steps? So there's a lot of heterogeneity. First, there's differences in the study populations. Our study is enriched for persons with a history of injection drug use. Other studies have focused on only veterans or more affluent men who have sex with men. So we need to ensure that the heterogeneity between these populations is distinguished. A good example is data from Italy has identified that there's a substantive prevalence of radiographic abnormalities among non-smokers with HIV infection. Yet further north in Denmark, pretty much all the respiratory morbidity is ascribed to the presence of smoking and lower income status. The other difficulty in comparing between studies is the heterogeneity of COPD itself, with lots of different approaches, be they clinical, physiologic, or other ways to measure and evaluate COPD. So we need improved phenotyping and subphenotyping of COPD. I know the ATS has a working group trying to make more harmonized approaches for respiratory diagnoses from electronic medical record data. We have interesting approaches in terms of radiography. We've been trying to look at airway wall thickness and quantitative emphysema scores for many years, but here's an illustration of using parametric response mapping, comparing expiration and inspiratory images and potentially identifying functional small airways disease. Here is highlighted in yellow. So there's novel CT biomarkers that can be employed. There's also classic biomarkers. We've looked at all of these or in the process of looking at them. An important caveat to consider is that what we've observed, particularly with our immunological studies, is that what's going on in the periphery does not necessarily reflect what's actually happening in the lung. So we need to leverage our long-term longitudinal studies with good biorepositories and also nest in studies that actually capture BAL and lung sampling in order to really understand what might be the mechanisms at play. And finally, we don't have to stop at just the clinic visit, but we can use wireless monitoring, in-home monitoring of symptoms, as well as lung function to get even more refined phenotypes of lung function. And finally, I'd like to focus on An area of great interest to us, particularly led by Dr. Sarath Raju in our group, along with Meredith McCormick, focusing on environmental factors and in particular air pollution and chronic lung disease. Worldwide, it's amongst the leading causes of obstructive lung disease, but even in Baltimore, there's substantial contributions to morbidity. So in SHIELD, we've had the self-report of a lot of different environmental exposures. And once again, a familiar theme is that we see an HIV effect modification where the exposure to secondhand smoke or NO2 exposure is associated with increased respiratory symptoms among the HIV-infected population specifically, but not among the HIV-uninfected population in general. We also have done a pilot of 30 individuals with a week of continuous monitoring. And again, looking at the WHO recommended limit of household particulate matter 2.5, we see the levels in both HIV positive and HIV uninfected individuals well above the recommended limits. And again, those with HIV having greater exposure. So that really emphasizes this continued HIV modification of exposures and risk factors. And we're following this up in the new SHIELD AIR study over the next several years with exposure assessment in the home in a much more detailed protocol, as well as on a much larger number of individuals. And with that quick overview of where we've been and where we're looking forward in terms of HIV lung disease, I'd like to thank the staff and the participants, as well as my colleagues, both at Hopkins and at different locations around the country. Thanks for your attention, and I look forward to our discussions.